Now we get to move up one joint further up to the carpals, and
Yes.
we are going to address the wrist and the case of painful wrist extension. So as we do this type of technique and approach it, the global technique for using for mobilizing the proximal row of carpals relative to the distal radius and ulna, we're going to use the web space of the hand.
Yep.
Did you experiment in other ways, yes. But you found that was the most effective way of doing it?
Yeah. We've spoken about hinge joints. Mm-hmm. The wrist I treat as a hinge joint. It's not a hinge joint. It's very mobile. It rotates and does everything. But regard the wrist as a hinge joint, and as a result, you can glide it medially or laterally or apply a rotation. But there's another category here. We've discussed hinge joints,
yes.
long bones. All the other bones come into another section.
And we're going to cover that just after we go through this, treating them whole as one, and then we'll come right back to the carpals.
Yes, the carpals, the facet joints, the sacroiliac joints, the ribs, they come into a third category, and we'll deal with that as we go through all the different.
Can you tell me what you look for when you're thinking about the placement of your hands to do this lateral glide of the carpals to promote wrist extension?
Yep. Use the web space, and when I correctly place my hand on Don's wrist, and I fixate proximally, of course, when I do this, when I'm correct, as I translate the bones towards the thumb side, the hand doesn't side flex. If I'm not accurately placing my hands and I come distal, all I'm doing is side flexing. Right. I've lost the translation.
So we need to stay off
you've got to make sure you're on the proximal row of carpals and not the distal row. Right. And so you're positioning. Look at my fingers straight out. But this will come up when we show techniques more specifically. But your hand placement is important.
But I just wanted to cover kind of the location of your hands, the direction of your forces towards the... and then if you were going to impart a rotation, how do you change your grip?
Here. This is quite simple. You don't need the same skills.
So you just squeeze with the lumbricals and you just kind of trap them and fix it and counter-rotate on the wrist.
And the wrist being complicated, of course, you might have to do both, some rotation and translation.
Very good. Very good. Okay, Brian, would you please move up to the wrist and treat the entire proximal row of carpals as one bone?
Of course I will. Right, patients come in. They've had a Colles fracture, they've had a wrist strain of some sort, and they've got pain with motion. Extension may hurt or flexion may hurt. And I did say in the introduction, I think you said it, that treat it as a hinge joint initially. Just treat it as a hinge joint. And as a hinge joint, the first thing you should do would be a translation at right angles to the movement taking place. And I have never, in all my years of using these techniques, ever translated it to the ulnar side. It's always been to the radial side. But don't ever make a hard and fast rule. If one direction doesn't work, please try the other. You're looking for something that's painless.
Let me just say that this is one of the distinctions that we usually get to our traditional mobilization, which would be mobilizing the same plane of the motion, and now we're mobilizing at right angles, as you said.
Before I came up with mobilizations with movement, the first treatment was distraction of the joint, and the second treatment was to mobilize it in the direction of bone movement that you expect biomechanically.
Right.
And does it work? Rarely. Okay. How do you do it? Let's put the hand up. I use the web space between my thumb and index finger, and I must locate on the proximal row of carpal bones. Can you just hold that up for a moment? Thank you. And when I translate across, if I'm accurate, these fingers won't move. If I'm not exactly where I should be, and I come a little further distally, say a centimetre, or maybe half an inch, and push, her wrist will tilt. And if she's got a painful wrist, that will never work. So you've got to be exactly on target. My fingers are pointing towards the camera because this keeps them out of the way when Jules, say, flexes her wrist. Just flex your wrist slowly, and I'm not in the way. If I were to grip, flex your wrist now, I'm in the way.
Yes. And I was watching your hand move as she moves, as her hand
all
moves.
the way back. Go slowly so that I keep that
And you're
correction
sustaining that correction.
all the way. And if it's a patient, they must give overpressure.
That's right.
The other point to make here is that if they've lost flexion and extension, as they might have after, say, a Colles fracture or some other wrist injury, that translation, if it fixes flexion, will also fix extension, which confirms the positional theory and not a biomechanical approach.
Right. Could you show me extension with overpressure?
Yes. Now, just hold it up there just for a minute so the camera can see. There's the translation. There's no pain. Back she comes slowly. Here comes my hand. And note where her fingers are. She's not stretching the fingers of this hand.
Right.
She's on the palm.
Right.
Back again. Sorry, I'm on target now. And back you come. And we would do, 10 repetitions and see how we get on.
I think some of the students that I would teach are astounded. I know that Julie was keeping her hand up so that it would not be in the way of the camera, but that some of the students are astounded that when the patient or the person who's acting as the patient as we're practicing in the class contracts their muscles, then it takes quite a lot of force to actually do the movement. But if they're able to relax their hand, and then you can move, it takes such little force. It's quite amazing.
Did you notice when you did that was side flexion?
Yes.
Can I see your hand for a minute?
Thank you very much. Now, if the functional limitation is really pushing up off the ground or pushing out of a chair, and it's a weight-bearing type of a component, we can do this in weight-bearing as well.
Yes, of course you can.
Oh, okay, good.
And now the other point to make, if a translation of a finger medially and laterally has not worked, you try a rotation. So here we will try a rotation and see if this helps. And how do you rotate? Again, just grasp the proximal row of carpal bones with the web space and just rotate it. Right. Now, just another point about rotation. Quite often after a fracture, this lower end of the ulna seems to be sitting up in relation to the radius, higher than the other side. Now, that could be for two reasons. It is, in fact, up on the radius physically, or the carpal bones have rotated, because as the carpal bones rotate, the end of this ulna is going to be more visible, and you're going to think it's sticking up. It's not. You need to correct the carpal bones to make that now fit snugly and restore movement.
And the way to tell what it is to just try it.
Try it, exactly. You just try it. Hey, that takes my pain away. Let's do it with overpressure. Now, it's a complex joint, and often as not, you have to do two things at once. You reposition it by translating it to one side and rotate at the same time. And you do both. And the patient comes slowly up. The patient now gives overpressure, and that's the treatment. And you do 10 repetitions, and you must get a result at the time, and it must be sustained. After a couple of days, it's still better.
And if you do the mobilization with movement and you're still having symptoms, could you show us the taping to sustain the repositioning?
Yes, yes. Well, yes, if you have latent symptoms, you could tape them. Now, let's show you the taping for rotation. That's so simple. Underneath, you're on the proximal row of carpal bones. And there I am locating on the proximal row of carpal bones. And now the taping lies obliquely across the wrist and is attached to the lower end of the radius. That is now going to maintain a rotation for you. Now,
does that also maintain a glide if that's what you needed to do?
No, because the emphasis is up and round, it's for that fault. To maintain a glide, you want the same lift underneath as on top. So, you put it on.
All right. So if I cross over your tape, I'll be correct in saying that I am on the proximal row of carpals. And then as I put it on, if we wanted the glide, I would put my hand over the top of the glide.
Yes.
I will ask
and
Julie to hold on to that.
Put on. Yep.
Yeah, and I'll glide as that happens. Yep. Relax your hand a bit. There we go. And over the radius. Yep. So the angle of the tape is now coming from carpals to radius.
Yes, on both sides.
Yes.
And if it's if it's on properly and it's effective, they know straight away. The patient can say, "Hey, I can move my wrist."
Okay, good. Retest for it. Yeah, but the proof is always in what happens after you take your hands off and the tape is still in place. If you've taped properly, the symptoms would be gone.
Yeah, that was showing where to put the tape, but correct as you're putting the tape on, so that you've now got it where it should be.
Okay. Now, if you had a problem and the patient's function and limiting factor, their asterisk sign, if you will, was the lack of the ability to push up from the floor, or when they were leaning on their hands, if they're doing something in weight bearing, can you use mobilizations with movement to mimic that?
Oh, this is lovely. I've just yesterday been teaching in, part of America. I forget where it was. But we have on the course a young man who can't extend his wrist without pain. He can't do a press up. So he comes out before 200 people, and his pain is right where the scaphoid is. Now, Cyriax years ago said that when you get to an extremity like a hand, if the patient says the pain is there, that's where it's coming from. If you've got a pain here or here, that's not where it's coming from. It could be here, it could be here, it could be here. Mm-hmm. But when you get to the wrist, if they've got a pain where the scaphoid is, this is a carpal bone, and it comes into that third category, hinge, long bones, and all the others. And with a carpal bone, like the scaphoid, all you do is to know, you must have the handling skills to locate on that carpal bone and just reposition it either ventrally or dorsally, and like the finger, you're looking for a pain-free movement and a painful movement.
And then you just stay out of the way, maintaining that new position of that bone.
The pain-free position.
Yes.
And that's, speaking of handling skills, give me your hand back again.
Yes.
Just as well it's clean. Now, I get hold of this. If I come up and they say, oh, that's a bit painful still, I imperceptibly, I change the directions. Mm-hmm. I'm coming in this direction, but I want no pain at all.
Mm-hmm. Now, what you, I think we have that on the slide over there as well, and that we have the scaphoid, the position that you see when you were putting your hand over my scaphoid, you were actually using the tip of your thumb, or you could use the side of your thumb. But
better the side.
Yes, yep. But you really don't want to use the pad of your thumb because, especially my thumb, it's quite wide and it spreads out and it's not specific enough with its contact.
That scaphoid is very small.
Yes.
We've got a skeleton here.
Yes, we do.
Here's the scaphoid here. And can you see that it's no bigger than my thumb?
Right.
Now, when you're repositioning a scaphoid to take the pain away and allow movement to occur, you've got to be right on that surface where it articulates with the lower end of the radius. And to do that, you don't use the pulpy part of your thumb, you use that border of your thumb so you can be specifically on the bone where you should.
And the other thing that I wanted to get to when we were at the wrist and the carpal bones is talking about moving into a functional position. We can also treat them in weight bearing. You can start the treatment perhaps non-weight bearing to see if you get the desired result.
Yep.
And don't forget the overpressure on the part of the patient. Okay, come on all the way back. Do you see how my distal hand moves with the moving partner?
Yep.
And but we can also do this on a table where your hand was down on a table, and I am now fixating down here your hand on the table and then gliding the distal radius and ulna to create the same alteration of the articulation. So that would...
He's done well, hasn't he?
Now, we also said that if you do your mobilizations with movement and there's still some symptoms left, we might be able to either teach the patient how to do self-mobilizations with movement or
sometimes tape them.
To reposition.
Yes, we'll show that.
Hopefully we'll show that a little bit later. Okay.
Yep. Good point.
Sounds very good. Brian, please move on up to the scaphoid and show us the mobilization with movement for the carpals.
Yes. If I'm teaching anywhere in the world and I've got a large class, I always ask if there are any people in the class who have pain with wrist extension when they put weight on it, where the scaphoid is. And if they do, I can almost guarantee I can influence that pain and make them feel better. And I've just been down in Florida, and there we had a guy who for 2 years, he has been unable to do a press-up, and he could not extend his wrist without pain. And we repositioned his scaphoid, and the next day, Brian, I'm symptom-free after 2 years. Now, you've got to have knowledge here. You've got to know exactly where that scaphoid lies, and you've got to be able to grasp the scaphoid and move it up and down, which confirms you know what you're doing. The repositioning of the scaphoid proximally, it's a case of locating on the lower end of the radius, grabbing the scaphoid proximally, because the scaphoid's about the size of my thumb, so you grab it proximally, and you go down and up, or in the direction of flexion or extension, translating one way or t'other, seeking the pain-free or painful direction. Both are important. You push down, it hurts. You lift up, it doesn't. That will be the direction that, or the replacement that you're going to apply to that bone. And with that replacement in position, they will extend the wrist.
Do you ever find it difficult as you're teaching people to use the side of their thumb rather than the pad of their thumb that they're used to mobilizing with?
Yes, and if they do that, it's not going to work. Right. You must just use that border of a thumb, because as I said, the scaphoid is the size of your thumb, and you want to be on part of it. So by rolling my hand over, I'm using that border to locate down or up. And down, I will now ask the patient, if it's painless, to extend the wrist.
All right.
Just an interesting teaching point here. When you extend your wrist, you can see the tendons appear where the snuff box is. They give you the snuff box. And when you get a patient to actively extend a wrist, when they really work hard at it, you're no longer in contact with the scaphoid. But somehow, because you repositioned the scaphoid before the motion started, it stays there. And the proof of the pudding is the fact that when I do it like this and correct it, even though I'm no longer on the scaphoid here, when Jules takes her hand and gives overpressure, there's no pain. And let go.
Good. Could I see that one more time as you just go through the movement?
Yes. Repositioned. In this case, it's repositioning down. That's pain-free.
Okay.
Jules comes into extension. I maintain that repositioning. But when she's up there, I can't tell you I'm on it.
No.
The guy in Florida, that didn't help. It was coming up. And if you base your therapy on biomechanical judgments, you would never have fixed him. Because I had to go up. And people say, why go up when it goes down in extension? You go up because it's now where it should be, and it will perform naturally, and down it goes in extension, which it must do. But it's got to be in the right place before you start.
So the indication is, again, now pain rather than your biomechanical expectations.
That's right. That tells you which direction to go.
Right.
It tells you which direction. Good.